So in this video, we're going to talk about incontinence. First, we have stress incontinence. With this, you're going to have leakage of urine with increased abdominal pressure. So for example, when you're laughing, sneezing, or coughing, you'll have some leakage of urine. This can occur when you have hypermobility of your urethra. You can diagnose this with a Q-tip test. So to treat this, you want to go from less intense to more intense. So you can start off by doing physical therapy with Kegel exercises. You can also give duloxetine. If that's not controlling their symptoms, then you can place a pessary. And if that's not controlling it, then you can place a sling. Next, we have urge incontinence. For this, your detrusor muscle or your bladder is overactive. So you're going to keep having the urge to go to the bathroom even though you just went and your bladder is basically empty. To treat this, you'll want to do time voids. So forcing yourself not to go to the bathroom, for example, every 10 minutes, you force yourself, okay, I can go every hour. So try to train your bladder in that way. Weight loss or cessation of caffeine and alcohol can also help with this. If lifestyle changes is not helping, then you can give medication. So for example, you can give bethanocol, which is an antimuscarinic, or you can also give the drugs listed below. For oxybutynin, be careful for prescribing it to elderly patients because it's highly anticholinergic. So that just means there'll be an increased risk for falls and an increased risk for delirium. Now, let's say the vignette is giving you a mixed picture of stress versus urge incontinence. You can't really tell. The next step would be to do urodynamic testing, and that'll help you figure out which one it's more likely so you can treat the patient accordingly. Next, we have overflow incontinence. So for this, the bladder or the detrusor muscle is not getting appropriate signals from the neurons, so your bladder is just over distended and you're going to have constant dribbling. So patients, for example, who have progression of diabetes or who have MS are more likely to develop overflow incontinence. They'll have a high post-void residual volume, so more than 150 milliliters left in the bladder, and the treatment for this is intermittent self-cap. Next, we have two other diagnoses that can possibly present kind of like incontinence, so let's go over those. First is a vesicovaginal fistula. So this is a connection between the bladder and the vagina, and these patients will complain of a continuous malordous discharge. There'll also be vaginal pooling of urine, and you can see red granulation tissue on the vaginal wall. And to diagnose this, you do a bladder dye test. And then lastly, we have a urethral diverticulum. And so this is an outpouching of the urethra. And on physical exam, you'll have a tender anterior vaginal mass. And for this, patients will describe a purulent urethral discharge and also pain with voiding.